Hello? Ṣé ẹ need anything? Ṣé ẹ ti jẹ àmàlà yín? Ah, as per Odogun. But Timber, will you stop that? Ìgbà mi ìmọ̀ pé ní plan fún kìíní. Táìpé mo mọ̀, tẹ́ bá notice, I did another muscle on it. I didn't want to do that kìíní pọ̀ pé no wahala. I didn't think you'd be able to do 2 nails today. Any downloading? Ẹ jẹ́ ní pharmacy àbí ní ibi náà. Mo máa tó bẹ̀rẹ̀ meeting mi by 8. Yeah, don't need TikTok for that. Okay, yeah, fine. Take. Bye-bye. No, did you even say hello, hi? Ìfẹ́ nípa.
Hello, mommy. Good evening, ma'am. How was your day, ma'am?
After the count of 2. 1, 2, go. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed, and so with peace and plenty, Nigeria and indeed the world may be blessed. Amen. Please, can someone confirm that I'm audible? Hello?
Loud and clear, sir.
Oh, okay. Okay. Thank you so much. So let me use this medium to welcome on board everyone here this evening. Sincere appreciation and welcome to the executive committee under the leadership of our amiable president, Dr. Muyosore Makinde, members of the education committee, members of the research committee, and publicity committee, and all the committee doing great things behind the curtain to ensure that so long, and of course the message of lifetime medicine is propagated. And let me welcome all every member of Solong to this discussion tonight. Okay, let me also welcome members of the Board of Trustees, led by our own Dr. Ifema Munye, to the call. And also let me specially welcome our speaker for tonight, Dr. Kehinde Temitope Oyen. Before I hand over to her, let me just take an abridged citation, an abridged bow of Dr. Kehinde Temitope Oyeniyi. She is a board-certified lifestyle medicine physician, a consultant family physician with area of specialization in adolescent and reproductive health, with a very keen interest in substance abuse among adolescents and youths. This is great. She is a fellow of the West African College of Physicians, and an associate member of National Postgraduate College of Physicians, and also improvement advisor of Institute of Health Improvement, IHI, and Quality Improvement Mentor. Currently working at one of the foremost tertiary health facilities in Lagos under the purview of Health Service Commission. Dr. Kehinde Temitope Oyeniyi had an MBBS degree from University of Lagos, College of Medicine in Idiaraba. She is a primary care physician who has been part of a different healthcare team, which advances public healthcare knowledge and practices by developing innovative and personalized care to patients, especially in the area of health promotion, disease prevention, control of epidemic diseases, women's health, especially during the transition phase, mental health, child immunization against communicable diseases, prevention of comprehensive maternal and child health, with a collective fulcrum of improving local and global health through integrated and collaborative services. Tonight, she will be speaking to us on the topic Fundamentals of Health Behavior Change, Part 2. In about 3 weeks ago, we had the Part 1, and it was very interesting and educative discourse. So please put your hands together via emoji, wonderful emojis, to welcome on board Dr. Kehinde Temitope Oyeniyi. Dr. Kenny, you are welcome, ma. Over to you, Dr. Kenny. Is Dr. Kenny there? Oh, wow. Dear devil internet. She's off the call. Let us just exercise a little bit of patience. So my president is here. I saw her on the call. Oh, is my network? The president is no longer on the call. Okay, Dr. Yeni, you're welcome back, ma'am.
Thank you. Sorry. Thank you so much. Sorry, I was having internet issues.
You are
Can you
muted,
see my
ma'am.
slides, sir?
Okay,
Hello?
let me check. Okay, it's up. Your slide is up. I think you have to put it on slideshow so that you should start from the beginning. All right. Showing clearly.
Okay, can I go ahead?
Please, the floor is yours.
Thank you. Thank you very much, sir. Good evening, presidents. All protocols duly observed. I'll be presenting fundamentals of health behavior change 2 under the following outline. Sorry. It's hanging, it's not moving. So, okay. So under the following outline, motivational interviewing, cognitive behavioral therapy, positive psychology, relapse prevention, factors to sustain behavior change, and summary. So motivational interviewing, just like the name says, it's defined as a collaborative, goal-oriented style of communication with particular attention to the language of change. It is used during the pre-contemplation and contemplation stage. It's designed to strengthen personal motivation for and commitment to a specific goal by eliciting and exploring the person's own reason for change within an atmosphere of acceptance and compassion. So it's also a guideline. It's a guiding style of communication that sits between following, that's good listening, and directing, giving information and advice. So it's a two-way thing. You listen to the patient, and the provider also, the patient also gives a feedback of what he has in his mind or her in her mind. Now, it's designed to empower people to change by drawing out meaning, importance, and capacity for change. Now, it's based on a respectful and curious way of being with people that facilitates the natural process of change and honors client autonomy. Now, there are 4 general principles of motivational interviewing. So for the purpose of exam, you can use the mnemonic end-stage renal disease, ESRD. So you have the empathy, express empathy, support self-efficacy, roll with resistance, and then discuss discrepancy. So for empathy, you want to show understanding of the patient and their situation. So this is not where you don't judge the patient, you put yourself patient's position and you show empathy. Then you want to support self-efficacy, which is the patient's confidence in their ability to succeed. Then you roll with resistance. Now, when a patient has a desire to change, there will definitely be some resisting factors they have that, why would I want to stop? Okay, I can give an instance, why do I want to stop smoking? So you can avoid discord in the relationship by remaining non-judgmental, listening well, and encouraging the patient to continue to share. So you roll with the resistance of the patient. Then you discuss the discrepancy between where the patient is and what the patient wants. So this is like the gap of the expected outcome, where the patient is and what the patient wants. So you hold this up to the patient without being judgmental and allow the patient to draw their conclusions. So the next slide, there are 4 core skills of motivational interviewing, also known as that's the open-ended question, affirmation, reflection, and summary. So for open-ended questions, these are questions that cannot be answered with 1 or 2 word response. So you engage the patient in open-ended questions because you want to hear everything the patient has to say. Then you have affirmation. You have genuine statements that accentuate a patient's strengths, intention, or efforts. Now, reflection. This has to be actively listening and intentionally offering a statement that conveys interest, empathy, while also seeking to understand what the patient is saying to guide the conversation forward. If we look at there's this term they call therapeutic alliance. It has to do with collaboration, partnership between the patient and the provider. And one of the things that for therapeutic alliance to occur, there must be open inquiry, there must be reflection and empathy. So in reflections, it can come in different ways. You can have the simple reflection, you can have the amplified reflection, you can have the double-sided reflection. Then when you notice that the patient is a bit ambivalent to change, you can employ what you call the shifting focus or the reframing type of reflection. You'll find this on page 44. Then lastly, after going through the open-ended questions, affirmation, reflections, you now give a summary. And this recaps of what the patient has shared, which communicates listening. So here, what happens here is that you help patients to create connection, create awareness, and they're in touch with their emotions with what they are vocalizing to the provider. So next slide. Now, we're talking about cognitive behavioral therapy. This is a form of psychotherapy and is based on the theory that the way the individual perceives a situation is more closely connected to their reaction than the situation itself. So an individual's perception are often distorted and unhelpful, particularly when they are distressed. So and this is very useful during the preparation, action, and maintenance stages. Remember I said for the motivational interviewing, it's useful for the first 2 stages of trans-theoretical model of change. That's the pre-contemplation and the contemplation. While this is for the last 3, preparation, action, and maintenance. Now, basically, what this does is that it helps with problem solving and a deeper understanding of the underlying challenges, more like a root cause analysis. You want to go deeper and see what is really going on apart from looking at it from the superficial level. So you see, as behavioral specialists, the behavioral health specialists generally perform CBTs. However, providers can apply basic rules using the coach approach. Now, before you begin the CBT with a patient, you go through the following steps. So there's a mnemonic HAP. You want to hear the internal dialogue. What are you thinking? Analyze the internal dialogue. Identify which cognitive distortions are present. Then you reconstruct your thinking. Write factual statements to replace distorted thinking. Then practice. Because realistic thinking does not come naturally, the more you practice, the easier it is to eliminate distorted thinking. So here, cognitive behavioral therapy helps patients to retrain their mind and also deal with the root cause analysis of the problem. So next slide. So for the basic principles of CBT that all providers can apply include, there are majorly 3. You recognize and reframe non-productive thinking. You build awareness of the underlying belief and emotions, and you walk through the ABCD method of behavioral change. So we'll talk about this in detail in the next slides. So you have to be aware of the different kinds of non-productive thinking, as also known as cognitive distortions. So there are about 10 common cognitive distortions, but I'll just talk about a few, maybe like 4 or 5, just for the purpose of exam. So you have the all or nothing thinking. That's feeling that there is no in between. It's entirely one way and no other. So imagine if somebody tells you that, feeling that there is no in between. It's either black or white. There is no gray. It's either this or that. Then overgeneralization, using limited factual evidence to hold a firm belief that is not true. So I give an instance. Let's say that in lifestyle medicine, it's just only male counterparts that we have there. We don't have female counterparts. So that's overgeneralizing without, having the clear facts on the table. Then you have mental filter, singling out one aspect of a situation to the complete exclusion of others that should be considered. Then mind reading, feeling certain of knowing what another person is thinking without having to ask. Then fortune telling, knowing that if this happens, that will definitely occur. Then the other ones you have magnification and minimization, you have personalization and blame, emotional reasoning, labeling, mislabeling, and disqualifying the positive. Now, to the next point of call, you want to reframe non-productive thinking. So how do you go about that? You help the patient to recognize their emotions and understand that by being more conscious of the non-productive thoughts that lead to negative emotions, they can consciously choose different thoughts that may lead to positive emotions. So how do you do that? You want to help the patient address the non-productive thoughts. So what's the person thinking? Okay, I want to stop smoking. I can't stop smoking. I feel better when I smoke. So you help patients, okay, you change that thought that you don't feel better when you smoke. You only feel a little bit, you feel a little bit high for that period, and it has an aftermath effect, long-term aftermath effect on your health. Now, in an exploratory way, you ask whether the patient's thoughts affect their behavior, ask about the evidence for and against non-productive thoughts. Now, you want to prompt the patient to share possible thoughts that can lead to non-productive emotions and might be getting in the way of behavior change. So the provider may reflect on the patient's statements, e.g., I noticed you said I have tried everything. What's the point? So you also have to, as a provider, you have to be careful how you re-echo this patient's thoughts so that you're not judgmental or trying to put a roadblock that there's no way out for this patient. So you ask the patient how they may see the situation differently. Is there a more neutral position? Has the patient indeed tried everything? Now you help the patient substitute more realistic interpretations in the place of non-productive thinking. The 6th point, you ask the patient for ideas about language or self-talk that can be used for different moments to support oneself and improve emotions about a change. Now, for example, if a patient is trying to quit smoking but finds himself desiring a cigarette, he could remember to say to himself, I know this is hard right now, but I can do this. These feelings will pass. I can relax in another way. So this is a form of self-talk and changing the narrative of his emotion to something positive. Excuse me. So, excuse me. So you ask the patient what they would like to do to practice new thinking strategies and more effective problem solving. Help the patient become more aware of their emotions. Explain that by being more conscious of the non-productive thoughts that lead to negative emotions, they can consciously choose different thoughts that may lead to positive emotions. So cognitive behavioral therapy is more or less like changing the narrative of what this patient holds firmly onto and making them have positive thoughts that can, enact the language of change. Now, for the second point, reframe thoughts and self-talk to support behavior change. So you want to teach a patient that adjusting thoughts can lead to a change in emotions. We can change an ongoing behavior. So examples of reframing thoughts include the patient thinks, okay, walking helps me to stay in shape and lose weight, but I can't walk outside if the weather is not right, if I'm too tired or my spouse can't walk with me. So now this is a reframe form of the patient's thoughts. This is a more reasonable thought. So these are excuses. So the patient to tell himself that, these are excuses. I can go to the mall and walk if the weather is not right, or use the treadmill we have at home. When I'm tired, walking could give me more energy. My walking is not dependent upon my spouse coming with me. The goal is to consciously choose different thoughts that may lead to positive emotions. Now, the last point is you recognize underlying beliefs that can interfere with behavior change. Now, you have unproductive thought processes can keep a patient from making positive and lasting health behavior changes. Now, these underlying beliefs reinforce negative thoughts and feelings and alter how patients see events, leading to a chronically negative and unproductive view of themselves. So basically, you want to reroute what this patient is thinking into a positive direction. And to counter unproductive thought processes, Dr. Albert Ellis developed a mnemonic device to help patients identify and reframe non-productive thinking. I'll be talking about that. So the mnemonic is ABC. It serves as a helpful framework for patients and providers working together to catch, to check, and challenge and change irrational beliefs. So you walk through the ABC method of behavioral change with the patient by asking, the first thing you want to ask is the action or the event. That's A. Then belief. Belief is, what beliefs do you have about what happened? Then what are the consequences of these beliefs? So, if you feel that taking cannabis is the best thing for you. You want to find out what are the consequences. Okay, it's affecting my finances, it's affecting my social life, my family members are complaining about this. Then how can you dispute those beliefs that seem to be distorted or unhealthy? Then what effect does this new way of thinking have on you feel, and how do you want to move forward? So this is the ABC by Dr. Ellis, ABCDE. So next slide, we're talking about positive psychology here. So it uses strategies for exploring that shift from focusing on problems to focusing on what is working well, both intrinsically and extrinsically, with the goal of increasing well-being and a measure by flourishing. This is used in all the stages of change. These are an MCQ question that can come out during the exam. Now, those who are flourishing not only feel good, they do good with a sense of purpose and higher engagement. Now, flourishing is not a measurement of transient mood, but is expressed as a positive emotion, engagement, positive relationship, meaning, and accomplishments. So flourishing is an ongoing thing. It's not a transient. It's not that you just feel good today, you're flourishing today, you're not flourishing next. It's consistent. It's on and on and on. It's unending. Now, these elements of positive psychology, excuse me. Now, excuse me. These elements of positive psychology, also known as PEMA, can be used to support behavior change. And what is the full meaning? Excuse me, please. And what's the full meaning of PEMA? Next slide. So you have positive emotions, engagements, positive emotions, engagement. You have relationships, meaning, and accomplishments. Now, for positive emotions, you want to encourage patients to recognize and find ways to generate positive emotions, including inspiration, hope, pride, interest, love, or amusement, joy, and also peace, serenity. You also want to encourage patients to also do a gratitude journal. So it's also a way to create positive emotions when you have it and doing it for its own sake. Now, flow experiences are derived from activities that are challenging, yet the patient has a skill to meet the challenge. In these experiences, patients have a sense for control, have clear goals, and are able to fully concentrate. So probably a patient likes jigsaw puzzles, likes to get involved in arithmetic, mathematical puzzles and all that. So it engages them and it leads to a flow. Now, the other one here is positive relationship. Now, strong relationships have the greatest impact on one's satisfaction with life, particularly growth-promoting relationships that include authenticity, empathy, and positive regard. When there's like I talked about therapeutic alliance between the collaboration between patients and the provider, partnership and collaboration. So when there's this positive relationship and there's authenticity and empathy and positive regard, this will have a great impact on what you want this patient to get involved in now, meaning this means the belief that one belongs to and serves something bigger than themselves. So you can belong to something, probably you're in a community or you have in it a spiritual engagement. You believe that this belief you belong to this set of, religious group, and you serve something bigger than yourself. So it comes in varying different settings. Now, accomplishments is the last one, the a result of working towards and reaching goals and experiencing success. Now, the ability to flourish as a human depends on one's fundamental ability to experience positive emotions like affection, love, enjoyment, happiness, playfulness, contentment, and satisfaction. Now, positive psychology acknowledges the value of positive emotions, engagement, relationship, meaning, and accomplishment. That's PEMA, the full meaning of PEMA. And one of the things it does is it improves attention, open-mindedness, creativity, and the ability to reach a strategic perspective. So it helps patients' attention span and concentration span. Now, there's a healthy ratio of positive to negative emotion built, and it builds resilience that enables patients to adapt to change. So when you use positive psychology for a patient, they have more positive thoughts compared to negative thoughts, and this helps them to be more resilient and able to adapt to and change. Now, positive emotions are vital for brain learning in the moment and for the patient's ability to successfully change over time. And it also is utilized in all the stages of change, from pre-contemplation to contemplation down to termination. Okay, so next slide. So what are the other benefits of positive psychology? It helps to build the patient's confidence. When you say positive things to people, naturally, it's just reflexively they will respond in a positive manner. So one of the things about positive psychology, just like the name positive psychology, it builds patients' confidence. It emphasizes patients' current skills and abilities. It reinforces autonomy and self-efficacy, which are keys to sustainable self-management. It emphasizes the patient's strengths and positive actions. It enhances resilience, like I said before, and helps to undo negative feelings. Increases the strength and impact of the patient-provider relationship, like I talked about therapeutic alliance. So now, relapse prevention. This is a very, very important topic, because when you have a patient that wants to change a habit, talking about the pre-consultation, where you talk about generally the generic discussion of the patient's health condition. Then you talk about the contemplation. Patient is trying to personalize the issues to change. Then you look at preparation, where this patient is making specific changes. So probably patient is a smoker, is looking at, and also specific changes, and also with a date. So probably patient is a smoker, wants to get rid of his ashtray, probably has vendors, wants to probably leave the WhatsApp group where they get these drugs or get these cigarettes and all that. So relapse prevention is something that you should look out for in patients when you're working out for them to change. Now, what is a lapse? A lapse is a short-term period when an action plan is not followed. So, after you have the preparation, this hasn't become a retrogressive habit again. So it's easier to address lapses than addressing relapse. So what's a relapse? A relapse is a sustained period where you've given the action plan after talking about what's going on. Can you hear me, please? Hello? I think I'm out.
Yeah, we can hear you.
Okay.
Yes, you're audible, ma. You're audible, ma.
Okay, thank you so much. Okay. So, like I said, a relapse is a sustained period where an action plan is not followed. So relapse prevention plan involves cognitive behavioral therapy. I can't seem to see this. Sorry. Okay, so for relapse prevention plan, it addresses addressing relapse is similar to forming a new action plan. So addressing a relapse is when the patient falls down and you have to now, okay, try to get up. What are we going to do? You don't judge, you show empathy, and you encourage the patient. So the next thing is that relapse can be challenging to address because unhealthy action has become a habit again. Now, the psychological implications of not meeting the initial goal can be very devastating, and the patient and provider must address thoughts and emotions that can arise from feeling of failure. So another perspective offered by the transtheoretical model of change. Let's remember that this is a non-linear model of change. It's a non-linear, so patients can move swiftly from one stage of change to the other, and they can even skip it. So it's a non-linear form of change, and it's called to frame this is called the recycling. Now we have to let patients know that this is a normal part of the change process. The provider can help prevent feelings of demoralization by providing empathy and helping clients reconnect to their motivators for change. And also the provider should get resources from clinicians on relapse prevention, which is very important, because the patients will just, not want to go back to the language of change. Now, for relapse prevention plan, what does it do? What does it entail? It addresses the following. It should be considered as an ongoing behavior change. So these plans assesses potential triggers for lapses and situations that may lead to ongoing lapses. So let's give an instance. If a patient wants to stop smoking, or you want to make sure that this patient doesn't go to public places where smoking is allowed. You don't want to connect back to your friends that are smokers. and all that. You don't want to go to hubs where they sell cigarettes. You just want to make sure that this patient stays away from, such triggers. So when might a lapse occur? So you want to find out under what circumstances, with whom, how does one notice a lapse before it becomes a relapse? Who to turn to during a lapse or a relapse? Now, relapse prevention tools, you want to identify relapse prevention support. So you have family, you have friends, you have social support, you have faith groups. You also want to establish a relapse reminder and a backup plan. So these are things that you have to put in place when you're planning the relapse for this patient. You have to have a relapse reminder and a backup plan. And patient must be the driver. The driver must be in the seat of this change and all that. So the patient will contact the provider's office in 3 weeks to check in with a family member, and will go to the patient's. So if the patient has issues with alcohol, this is an example. So you know that in social gatherings, they will definitely serve alcohol. So you want like somebody that will put you in check. You go with a family member, a family or a friend, and go to the party to make sure that you don't take alcohol. So it's like people that will keep you in check, and you have a backup plan. So what are the 4 Ds of relapse plan? We have the delay. So once this, you encourage patient that once you notice this thing, if you have the urge to take a shot or to take a puff, a drag of cigarette, or to take any form of substance abuse, you encourage the patient to delay the feeling. Then look for something to distract them. Then deep breathing. This helps with distress. Then to decatastrophize. So these are the 4 Ds of relapse plan. So now, what are the factors that support sustained behavior? The first one, there are 3. Develop growth promoting relationships. So like I said, relationships are very, very key. So when you have people will grow towards relationships. Relationships are the source of meaning and empowerment. Now, patients should be able to discuss goal progress without experiencing judgment, criticism, or shame, regardless of the outcome. So regardless of whatever this patient comes to you with, whether this patient was able to, probably is trying to lose weight, and you told the patient you have graded exercise, okay, within 1 week, do 20 steps, within 2 weeks, do 30 steps. So probably patient comes back to see you after 5 weeks and has only done 10 steps. You do not judge this patient. You all encourage this patient. You motivate this patient. Tell this patient that you've done very well. And let's see how we can move to another phase of more exercises. What can we do? So positive reinforcement and positive feedback will help this patient move towards the language of change. Now, patients should be able to discuss goal progress without experiencing judgment, criticism, or shame, regardless of the outcome. That's what I just explained. Now, so what are the second point is actions should be fueled by the patient's own motivation. Now, you identify the future-focused behaviors that will contribute to meaning. Identify the intrinsically motivated behaviors that can lead to flow. Remember that flow has a lot to do with engagement. We talked about in the PEMA. Then, the second one here is you build the patient's confidence in trying new behavior. So you focus on strategies for increasing self-efficacy, identify role models for behavior. So you want to, make reference to, look at this person. This person used to smoke. He smoked for like 30 years, but for the past 5 years, he hasn't smoked. So it's doable. You can do it. He has been sober for about 5 years. So you also want to name the benefits and the reason for change. You also want to talk to patients about this. You engage in goal setting that is appropriate for the stage of readiness. Remember that the action plan here, you're talking about your specific, your SMART goals here for this patient. Then you celebrate small successes with new behavior. So you must amplify every new achievement this patient comes. It will have a very positive effect on this patient. Now, you also want to list internal and external sources that will support the change. Now, have a clear plan of action. Now, you set goals that are specific and provide a level of challenge that matches one's skill set. You track progress to recognize successes and triggers for challenges. Then you keep an attitude of experimentation that expects relapse and looks out for learning. So this is more or less like on learning, relearning, and learning again. So it's like an open board for this patient to change. So now, this is very important. You cannot overemphasize the role of family and other support to initiate and maintain health behavior change. Now, for family support, it has a lot to do with family values, goals, habits. healthy habits around food, and very importantly, kind of parenting we have. Is it the type of parenting that the parents are present or they are absent parents and all that. So you also want to talk about social support. When social support is present, people have a better long-term success with weight loss. It's been found that social support. So you see a patient that's trying to lose weight. One of the things you can do is that connect them to people that are also trying to lose weight, WhatsApp group and all that. This will keep them in check and helps them to, discuss their progress plan. And it's a way to support them and gear them towards losing weight. Then you have group coaching and shared medical appointments. This cannot be overemphasized. And lastly, you have digital technology. So you have apps, wearable devices, telehealth, video, phone counseling, or high-tech, high-touch, a combination of digital and live counseling. So you have digital technology to help you to probably send reminders, keep you on track, help you know that, okay, fine, you've not done up to 10,000 steps, you've just done about 3,000, you still have about 7,000 to do. So you see how you can engage yourself probably later in the day before you go to bed to complete your 10,000 steps. Now, in summary, I put this together because these are a few things that, one should be able to quickly touch on. And these are very salient points. So in summary, I presented Fundamentals of Change, Part 2. And motivational interviewing is used mainly for the pre-contemplation and the contemplation stage. There are 4 general principles, which include the empathy, self-efficacy, role with resistance, and discrepancy. There are 4 core skills for motivational interview, which is also known as the open-ended questions, the affirmation, reflections, and the summary. Now, CBT is most useful during the preparation, action, and maintenance stages. They assist in problem solving and a deeper understanding of underlying challenges. Now, we're talking about positive psychology here. It has elements known as PEMA, and this can be used to support behavior change in all the stages of change. Now, lapse, like I said shortly a few minutes ago, is a short-term period or a slip when an action plan is not followed, while relapse is a sustained period when an action plan is not followed. Now, relapse prevention plan should be ongoing, assess potential triggers for lapses and situations that lead to ongoing lapses, and the patient must be at the driver's seat of change. So the patient must be the one in charge of this change. When a child falls down, we try not to shout or scream, because what's next thing the child will do? The child will start crying. So you want to see how you encourage the child. Oh yeah, stand up, you can do it. So you want to make sure that this patient is the one in charge of this language of change. Now, the role of family, social support, group coaching, shared medical appointment, digital technology cannot be overemphasized, cannot be ignored. Thank you very much.
Please, can we just appreciate Dr. Kende Oyeni for that wonderful presentation? Yes, let's keep it coming. Let's keep it coming with those emojis of the fundamental of health behavior change. And she has actually told us this night on the use of motivational cognitive behavioral therapy. I think every time